Hello and welcome, fellow student doctors. Today, we will discuss cerebral edema, which literally means brain swelling. With the brain being protected, but also trapped, within the rigid bones of the skull, even slight swelling can lead to a rise in intracerebral pressure that can subsequently reduce cerebral perfusion pressure or blood flow to the brain. It gets worse from there. As the brain continues to swell and cut off its own blood supply, it can herniate, causing massive brain damage. Undoubtedly, in your training, you will face a patient who has cerebral edema, be it from a stroke, trauma, tumor, or other cause, and it will be up to you to use the information in this lecture to develop a differential diagnosis based on their suspected type of edema and treat it quickly. Time is brain, friends. We are in for an interesting discussion. Let's go ahead and get started. To prepare you for test day, you will be able to 1. Differentiate vasogenic, cytotoxic, osmotic, and interstitial subtypes of cerebral edema. 2. List causes of cerebral edema based on subtypes. 3. Describe the potential consequences of cerebral edema. And 4. Describe the potential treatment methods for cerebral edema. Cerebral edema is defined as the accumulation of fluid in the parenchyma of the brain. Parenchyma refers to the functional portion of an organ compared to its structural framework or capsule. When approaching the types of cerebral edema, the first question to ask is whether the blood-brain barrier is intact. If the answer is yes, the blood-brain barrier is intact, then subtypes of cerebral edema include cytotoxic causes, such as during the early phase of ischemia, the late phase of trauma, and when there is elevated levels of ammonia in the blood, such as in the setting of liver failure. The blood-brain barrier is also intact for interstitial causes of cerebral edema, which means fluid collects in the interstitium or space between cells. All causes here center around cerebral spinal fluid collecting in the interstitium from hydrocephalus or idiopathic intracranial hypertension. Lastly, the blood-brain barrier remains intact for osmotic causes of cerebral edema. Essentially, differences between the osmolarity of the brain and the blood vessels differs due to the presence of hyponatremia from SiADH or iatrogenically through the rapid correction of hyperglycemia or hypernatremia in the healthcare setting. Overall, these subtypes of cerebral edema leave the blood-brain barrier intact, as you can see in this image. As background, the blood-brain barrier's entire goal is to prevent the movement of fluid and substances between the blood and the brain. It is composed of non-fenestrated endothelial cells, which means they lack holes in their membranes to prevent transcellular movement, with extensive tight junctions between those endothelial cells whose role is to prevent paracellular or between-cell movement. The barrier is further reinforced with the basement membrane of those endothelial cells, as well as parasites which wrap themselves around those endothelial cells, and they are not pictured here. Finally, astrocytes wrap their foot processes around all these layers to further prevent the transport of materials from the blood to the brain. As we will see on the coming slide, these causes of cerebral edema do not alter the blood-brain barrier to cause swelling in the brain. Looking back at our original question, if the blood-brain barrier is not intact, then the subtype of cerebral edema is called vasogenic edema, with causes including the late phase of ischemia, the early phase of trauma, hemorrhage, inflammation, central nervous system masses, toxins, and high-altitude cerebral edema. All processes that damage the blood-brain barrier, as we'll discuss. The cytotoxic, vasogenic, and osmotic subtypes of cerebral edema can best be understood by comparing them. We'll save the interstitial subtype for the next slide. Using an example, let's start with cytotoxic edema, which occurs in the early phase of ischemia, such as in the setting of a thrombotic stroke. That leads to the depletion of ATP. Why? Well, ischemia refers to the lack of adequate blood flow to a tissue, here the brain. Without proper levels of oxygen, oxidative phosphorylation via the electron transport chain cannot proceed effectively to create ATP. So ATP depletion leads to dysfunction of the sodium-potassium ATPase, which requires a lot of ATP to run normally. Usually, the sodium-potassium ATPase keeps intracellular sodium levels low and extracellular sodium levels relatively higher. Without enough ATP as fuel, this balance flips, such that intracellular sodium increases and extracellular sodium decreases. This causes cells to swell because water flows where sodium goes. With sodium building up intracellularly, water flows into cells, causing them to swell up. This is high yield, so listen up. Cellular swelling is a reversible form of cellular injury, as this image shows. In the setting of an ischemic stroke, if the blood clot is removed in time, the cells, the neurons, can be saved. They are just swelled up, but the fluid can leave the cell if oxygen is delivered, allowing ATP to be produced to allow the neurons, sodium-potassium ATPase pumps, to pump that fluid out of the cell. Overall, with the sodium being trapped inside of those cells, they swell up. Fluid shifts occurs, leading to cerebral edema. Why? Sodium builds up intracellularly, and so the extracellular sodium concentration is decreased, setting up another gradient between the brain and its blood vessels, such that sodium and the fluid flow out of the blood vessels and into the brain's extracellular fluid, causing edema in the cerebral parenchyma. This describes the early phase of ischemia. As you may suspect, if blood flow is cut off for too long, we enter the late phase of ischemia, where irreversible injuries to cells occur, resulting in necrosis or death of cells of the brain and the blood-brain barrier. With necrosis of those cells in the late phase of ischemia, the blood-brain barrier breaks down, neurons begin to die, and there is an influx of fluid into the brain, a process called vasogenic edema, where the blood-brain barrier is no longer intact, and so we get cerebral edema. A similar comparison between cytotoxic and vasogenic subtypes of cerebral edema can be made in the discussion of trauma. In the early phase of trauma, the sheer physical force of the insult leads to the disruption of the blood-brain barrier, an influx of fluid characterizing another cause of vasogenic edema, leading to cerebral edema. Approximately 45 minutes after the onset of vasogenic edema during a traumatic brain injury, cytotoxic edema begins to occur during the late phase of trauma. Why? Two reasons. First, the brain is already swelling due to vasogenic edema, leading to increased intracranial pressure and decreased cerebral perfusion pressure as the lumens of blood vessels in the brain are progressively decreasing in size due to the increasing pressure within the skull. This sets in motion ischemia, a lack of oxygen, and, subsequently, a depletion of ATP. Additionally, the ruptured cells in the early phase of trauma lead to the release of various mediators that eventually cause shifts in ionic distributions, with sodium building up intracellularly. With depletion of ATP and ionic shifts of fluids, cytotoxic edema occurs in the late phase of a traumatic brain injury. One last high-yield cause of cytotoxic edema is elevated ammonia levels in the blood, which can be caused by liver failure. Essentially, excess ammonia causes depletion of ATP in two high-yield biochemical mechanisms. First, excess ammonia is converted into glutamine within mitochondria, leading to mitochondrial damage and depletion of ATP. Secondly, excess ammonia depletes the TCA cycle of alpha-ketoglutarate, abbreviated alpha-KG, a key intermediate of the TCA cycle, leading to yet another mechanism of reducing ATP production. This biochemistry explains why elevated ammonia levels in the blood leads to cytotoxic edema and cerebral edema in the setting of liver failure in patients presenting with hepatic encephalopathy. Overall, cytotoxic literally means toxic to the cell. These processes are toxic to the cell because they cause them to swell up, predisposing the cells to rupture and death via necrosis. Get it? Cell swelling that can lead to cell death, cytotoxic edema? Turning our attention back to vasogenic causes of cerebral edema, let's complete that box. Try not to memorize, just use logic. The logic is anything that causes disruption of the blood-brain barrier can be a cause of vasogenic edema. So, central nervous system masses, like tumors, can physically disrupt the blood-brain barrier. Inflammation, such as in the setting of encephalitis, can disrupt the blood-brain barrier as well as the body tries to recruit fluid and immune cells into the brain. HACE stands for high-altitude cerebral edema, basically the extreme form of acute mountain sickness, which occurs when the brain experiences significant hypoxia at elevation. This may lead to a compensatory increase in cerebral blood flow that is so brisk it actually damages the blood-brain barrier, resulting in vasogenic edema. Conversely, this hypoxia may set into motion cytotoxic edema as well due to ischemia, which we know can cause both forms of edema. More straightforward examples include toxins, such as lead, that damage the blood-brain barrier. Lastly, the most high-yield cause to know for exams is hemorrhage, especially in the setting of hypertension, which can lead to bleeds in the basal ganglia and cerebellum, as this image shows by the red arrow. The boards want you to understand that hemorrhage in the brain disrupts the blood-brain barrier and leads to vasogenic edema, a high-yield point. Overall, all these causes lead to vasogenic edema, a subtype of cerebral edema. Lastly, osmotic edema is another subtype of cerebral edema where the blood-brain barrier remains intact. Essentially, osmotic edema occurs due to an osmotic insult that leads to fluid shifts. For example, in the setting of SIADH, hyponatremia is present. Similarly, if hyperglycemia, such as during diabetic ketoacidosis, or hypernatremia is corrected too rapidly in the healthcare setting, another osmolar gradient is established between the brain and its blood vessels, such that the blood vessels have a lower plasma osmolarity than the brain. The blood-brain barrier is permeable to water. The brain needs the drink, right? So water flows from low to high concentrated areas, which can be remembered with the rhyme, hypotonic to the hypertonic flow, osmosis. Let's go. Ultimately, the brain becomes more concentrated than the plasma in its blood vessels, leading to a shift of fluids into the brain, causing osmotic edema, a subtype of cerebral edema. The last subtype of cerebral edema to cover is interstitial edema. This is a CSF, cerebral spinal fluid, flow problem. Essentially, the normal flow of CSF is impaired, resulting in higher ventricular pressures. This physically forces CSF across ependymal tissue and into the brain, specifically into the interstitium of the brain, which is the space between cells of the brain. Impairment of normal CSF flow can be caused by communicating hydrocephalus, so called because the ventricles can communicate via CSF with one another. There are no physical blockages in the ventricles. However, the arachnoid granulations cannot absorb CSF into the venous system for reprocessing. This may occur in a patient recovering from a Neisseria meningitidis infection. Why? Because Neisseria meningitidis, as it is so named, causes meningitis that can lead to scarring of the arachnoid granulations and, subsequently, communicating hydrocephalus and interstitial edema. Another cause of hydrocephalus that can lead to interstitial edema is called non-communicating hydrocephalus, and it is so named because a mass, such as a cyst in the foramen of Monro as pictured here with the red arrow, impedes the normal CSF flow between ventricles. That is, they can no longer communicate with one another via CSF fluid because there is a blockage in the ventricular system that physically forces cerebral spinal fluid out of the ventricular system and into the interstitium of the brain. Like hydrocephalus, idiopathic intracranial hypertension can also lead to increased ventricular pressures, leading to interstitial edema. This condition is also called pseudotumor cerebri, with pseudo meaning false to indicate the false or non-existent presence of a tumor in the cerebri or brain causing increased ventricular pressure, like would be expected from non-communicating hydrocephalus. However, there is no tumor present, hence pseudotumor cerebri. Regardless, idiopathic intracranial hypertension is caused by a mismatch between CSF production and reabsorption, with associations being best remembered with the female toad mnemonic. The classic patient to develop idiopathic intracranial hypertension is an obese female, especially one taking tetracyclines, vitamin A supplements, or danazol. Lastly, I want to mention hydrocephalus ex vacuo, which is not, I repeat, not capable of causing cerebral edema. This is often listed as a distractor for answer choices. In this condition, intracerebral pressure is normal, and the ventricles only appear large and stretched out because brain tissue is missing. It is atrophied due to neurodegenerative conditions such as Alzheimer's or Huntington's disease. Cerebral edema is a life-threatening condition because it leads to an increase in intracerebral pressure, which leads to a decrease in blood flow to the brain, a decreased cerebral perfusion pressure, and eventually herniation of brain tissue, as the brain is enclosed within a rigid, bony skull, so if it swells, it has no place else to go. This is problematic and can result in 4 types of herniation syndromes. In a cingulate or subfalcine herniation, the cingulate gyrus herniates below the falx cerebri, leading to compression of the ipsilateral, or same side as the herniation, anterior cerebral artery. The ipsilateral anterior cerebral artery supplies the contralateral legs motor fibers, leading to paresis or weakness on the contralateral side. In a central or downward herniation, the thalamus, hypothalamus, and temporal lobes are forced transtentorally through the tentorium cerebelli, leading to pressure on the brainstem and rupture of the paramedian basilar arteries, called direct hemorrhages. This can lead to posturing and death. The uncus is the medial portion of the temporal lobe. So an uncal herniation involves herniation of the medial temporal lobe through the tentorium cerebelli, which causes the following: an ipsilateral cranial nerve 3 palsy, which results in loss of the parasympathetic fibers of cranial nerve 3, leading to a blown pupil, as well as loss of the motor function of cranial nerve 3, leading to a down and out eye, as shown by the red arrow here. This also leads to ipsilateral compression of the posterior cerebral artery, leading to contralateral homonymous hemianopsia, a visual defect. Also, the patient may exhibit ipsilateral paralysis, which is unusual. Usually, the paralysis is on the contralateral side or opposite side of the lesion in the brain. Well, it is more complicated here, as the uncus can press on the ipsilateral cerebral peduncle, causing pressure within Kernahan's notch, which is felt by the contralateral cerebral peduncle, as shown in the image. This leads to paralysis on the same side of the lesion, as the opposite side of the cerebellar peduncle is damaged due to this anatomical shift within the brain due to the uncal herniation. Lastly, the cerebellar tonsils can herniate into the foramen magnum, the conduit from the brain to the brainstem and spinal cord. This is called a tonsillar herniation and puts significant stress on the brainstem, especially the medulla, leading to cardiorespiratory depression and death. Cerebral edema and the resultant increase in intracerebral pressure and decrease in cerebral perfusion pressure have other consequences beyond the herniation syndromes we discussed. Specifically, the formation of a Cushing ulcer, which is a gastric or stomach ulcer. The elevated intracerebral pressure leads to increased vagal or cranial nerve 10 stimulation. As a predominantly parasympathetic nerve, this leads to the release of acetylcholine onto the parietal or acid-producing cells of the stomach. Where in the stomach are these parietal cells located? They are predominantly located in the fundus and body of the stomach, a very high yield point. And so, the release of this acetylcholine binds to the M3 receptors and also leads to the release of GRP, gastrin-releasing peptide, both of which lead to an increase in acid production and the formation of a Cushing ulcer. This is one reason why you will see patients with brain injuries in the ICU on proton pump inhibitors. I think of a Cushing ulcer anytime I see my cat named Penny, meow, laying around on the couch cushions all day. Like, you better move, kitty cat. You're going to get a skin ulcer from laying around all day on the cushions. A Cushing ulcer. Meow. Next, patients may develop the Cushing reflex due to a decrease in cerebral perfusion pressure. The Cushing reflex is a triad of a decreased respiratory rate, a decreased heart rate, and an increased blood pressure. Let me explain. The increase in intracranial pressure leads to brainstem compression, which compresses the medulla, which controls respirations and leads to a decrease in the respiratory rate. The increased intracranial pressure also leads to a decrease in cerebral perfusion pressure. This makes the body have a literal panic attack because the brain is not receiving enough blood. So, a sympathetic response is initiated, causing the systolic blood pressure to increase. Then the baroreceptors in the blood vessels, such as those in the aortic arch, sense this increase in systolic blood pressure and initiate a compensatory parasympathetic response, causing bradycardia or a decreased heart rate. All of which characterize the Cushing reflex, which is a triad of bradycardia, hypertension, and a decreased respiratory rate. When treating cerebral edema and the resultant increase in intracranial pressure and subsequent decrease in cerebral perfusion pressure, it is important to maintain cerebral blood flow and prevent secondary brain injury, such as from herniation. Management follows a stepwise progression, with step 1 being to assess and address the ABCs, airway, breathing, and circulation, followed by identification of the cause of cerebral edema using the 4 subtypes we have discussed, as they each have targeted treatments. For example, if it is a thrombotic stroke causing early ischemia and cytotoxic edema, thrombolytics can be considered. Conservative treatments can also be used in step 2, such as elevating the head of the patient's bed. Just like you would elevate a sore ankle to reduce swelling, you would elevate the patient's head to reduce venous return and swelling. Sedation can be used to reduce pain, discomfort, and reduce metabolic load on the body, along with temperature and fluid regulation. From here, medical therapies can be utilized if needed with hyperosmolar therapies, such as hypertonic saline and mannitol. These are osmotically active agents, such that they make the plasma in the blood vessels of the brain more concentrated than the brain tissue, using the hypotonic to the hypertonic flow, osmosis. Let's go. Rhyme. We know that fluid will leave the now more relatively hypotonic brain and enter the now more relatively hypertonic blood vessels, reducing cerebral edema. It is also high yield to know that steroids are used to reduce cerebral edema in the setting of vasogenic edema that has an inflammatory component, such as from infection, autoimmune disease, and tumors such as cancers like glioblastoma multiforme. All of these cause some degree of inflammation in the central nervous system that lead to vasogenic edema, cerebral edema, that can be reduced by steroids. Lastly, in the setting of refractory cases, hyperventilation can be used if the patient is mechanically ventilated to decrease CO2 levels, which leads to cerebral vasoconstriction. If blood vessels decrease in size, less fluid enters into the brain and less volume is taken up physically by the actual blood vessels themselves. It is so high yield, friends, to know that cerebral blood vessel diameter is directly proportional to CO2 concentrations in the brain. If CO2 levels rise in the brain, blood vessels dilate because they want to get the fluid there to take away that CO2. Conversely, if CO2 levels decrease in the brain, which would happen with hyperventilation, the blood vessel diameters would decrease to decrease their volume in the brain to relieve some of that cerebral edema. So, hyperventilating a patient with cerebral edema is usually done as a method to bridge them to definitive therapy, such as with surgery. If all else fails, CNS metabolic needs may be further reduced with the induction of a coma and/or hypothermia. Alright friends, it's time for a flash quiz. The question reads that a 75-year-old man with chronic kidney disease secondary to hypertension presents with the abrupt onset of a severe headache and weakness on the right side of his body. A non-contrast head CT is performed with the results shown. Which answer choice best corresponds to this presentation? Take a moment, read through the answer choices, and select one. The correct answer is D. Pictured here is hemorrhage in the basal ganglia, specifically the putamen. This area of the brain is supplied by the lenticulostriate arteries, which branch off of what vessel? The MCA, the middle cerebral artery. That is why A is a distractor, because you probably knew this was MCA territory. Is the blood-brain barrier intact here? No! For all that blood to pour into the brain, the blood-brain barrier was disrupted, making this a form of vasogenic edema that of course causes an increase in intracranial pressure. Recall that vasogenic edema is the only subtype of cerebral edema where the blood-brain barrier is disrupted. Notably, the patient had weakness on the contralateral side of the body, as the hemorrhage occurred in the left putamenal territory, so weakness presented on the right side of his body. This entire discussion on cerebral edema is clinically relevant, especially in terms of imaging, where CT or MRIs can use contrast injected into blood vessels to determine if blood vessels are intact. Here, this person had an MRI with contrast injected, and you can see the bright white collection of blood in the basal ganglia, the putamen. Whenever you see bright blood in the basal ganglia, that is almost always due to hypertension that resulted in hemorrhage. There are clues in the stem of the question that hint at hypertension as the precipitating factor for this patient, as he is of older age, has chronic kidney disease due to hypertension, and now presents with a severe headache. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. Cerebral edema refers to swelling in the parenchyma of the brain and has 4 subtypes. Overall, cytotoxic, osmotic, and interstitial causes of cerebral edema all leave the blood-brain barrier intact, and as such are colored in green. Vasogenic edema is in red because it is caused by disruption of the blood-brain barrier, such as from the late phase of ischemia, early phase of trauma, hemorrhage, inflammation, brain masses, toxins such as lead, and HACE, or high-altitude cerebral edema. Conversely, cytotoxic edema is caused by the early phase of ischemia, late phase of trauma, and liver failure causing elevated ammonia levels in the blood, all of which lead to ATP depletion within cells with resultant sodium-potassium ATPase pump dysfunction and fluid shifts due to ionic concentration differences that cause cells to swell and possibly die. That is cytocell toxic edema. Osmotic edema also involves fluid shifts leading to cerebral edema, with causes including hyponatremia in the setting of SIADH, as well as the rapid correction of hyperglycemia during diabetic ketoacidosis and the rapid correction of hypernatremia in the healthcare setting. Ultimately, These processes cause the plasma of the brain's blood vessels to become hypotonic compared to the hypertonic brain, leading to the hypotonic to the hypertonic flow. Osmosis. Let's go. Interstitial edema is a cerebral spinal fluid flow issue where communicating and non-communicating hydrocephalus, as well as idiopathic intracranial hypertension, lead to disruptions in the normal flow of CSF, resulting in increased ventricular pressures that ultimately squeeze CSF fluid into the brain's interstitium or areas between cells. In terms of consequences, cerebral edema leads to a rise in intracranial pressure and subsequent decrease in cerebral perfusion pressure, all of which can lead to brain herniation syndromes. Additionally, cerebral edema can lead to the Cushing reflex, which involves brainstem compression, leading to a reduced respiratory rate, a decreased cerebral perfusion pressure, which then leads to a sympathetic response and hypertension. This hypertension is then felt by baroreceptors that cause a compensatory parasympathetic response and ultimately bradycardia. Make sure you know that very high-yield triad of bradycardia, a reduced respiratory rate, and hypertension for the Cushing reflex. That will be on your exam. In terms of cerebral edema leading to a Cushing ulcer, this occurs due to increased intracranial pressure that leads to increased vagal stimulation and resultant acid production from the parietal cells in the stomach. Lastly, cerebral edema can be treated in a stepwise manner with ABCs in identifying and treating the cause being central in step 1, followed by conservative methods such as head elevation in step 2, with step 3 involving medical therapy such as hyperosmolar agents to reduce intracranial pressure via osmotic flow, and steroids if the cause of edema is vasogenic and has an inflammatory component. Step 4 is utilized when all else fails and involves hyperventilation to reduce CO2, which causes cerebral vasoconstriction to reduce intracranial pressure and/or bridge the person to surgery. Friends, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always, always, always remember, there's a great big beautiful tomorrow.